Hey guys, welcome back to my channel, The ENT Resident. Today I'll be starting a series on tracheostomy. I'll be talking about different parts of it in different videos. In today's topic, I'll be discussing about what is tracheostomy, what are the functions of tracheostomy, what are the physiological changes that tracheostomy has. And then after that, I'll talk about the indications, the contraindications, the different types of tracheostomy, and lastly, what are the advantages and disadvantages of performing a tracheostomy? You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So there are two terms over here that we need to know. The first term is tracheotomy and the second term is tracheostomy. Now, what is the difference in between these two terms? Now, tracheotomy is, if we look at the image here, this is what a tracheostomy looks like. Now, the tracheotomy is, if we see this is the trachea over here, if we just make an incision, a surgical opening in the trachea, that part is called tracheotomy. So, tracheotomy is actually one of the steps in the surgery tracheostomy. Whereas, if we look at tracheostomy, tracheostomy is the surgery where we create a stoma at the skin surface which leads into the trachea. So, tracheotomy was just making an opening in the trachea, but when we connect that opening with the help of a stoma on the skin surface, that is what we call as tracheostomy. And tracheotomy is just a step in tracheostomy surgery. Now let's look at what are the functions of tracheostomy. By doing that, what are all the things that we are achieving? First of all, if any patient is suffering from any kind of upper airway obstruction, that is relieved by doing a tracheostomy. Secondly, tracheostomy also helps in reducing the dead space in the tracheobronchial tree. So, a normal dead space is about 150 ml. This undergoes a reduction by about 30 to 50% depending on the individual. So, that is one more function of tracheostomy. And third, it also helps in reducing the resistance to the airflow. This reduced resistance will further reduce the force which is required to move the air, hence, resulting in an increase in the total compliance and therefore more effective alveolar ventilation. So, these number 2 and 3 points together, it leads to improved airway ventilation in the patient. Next function is the tracheostomy is also protecting against any aspiration of blood and secretions. So this can easily happen in case of a patient who is in coma, who is unstable, or suffering from maybe bilateral abductor palsy. In all of these cases, it will help you in protecting against aspiration of blood and secretion. Next function is tracheobronchial toileting becomes easy by tracheostomy. You can just aspirate all the secretions and permit gas diffusion. And lastly, tracheostomy can be used for giving intermittent positive pressure ventilation, for giving anesthesia, for delivering medications, and even for humidification. So, these are all the functions of having a tracheostomy. Now, let's talk about what are some physiological effects that we'll see as a result of tracheostomy. So, the first one I have already mentioned, a normal respiratory dead space is about 150 ml. By doing a tracheostomy, there is a reduction in the respiratory dead space by about 30 to 50%. Second is it does a bypass of the larynx, because of which there is loss of cough as well as phonation in the patient. Third, because it is bypassing the upper airway, there is a loss of passage of air through the nasal mucosa. Therefore, there is also loss of nasal mucosa filtration as well as humidification. So, in a normal person, when we breathe in through our nose, the physiology of the nose has a lot of functions over here. One of them is filtrating out particles and bacteria, and secondly, it also helps in humidification of the inspired air. Both of these functions are lost when we do a tracheostomy. Next effect is that it also ends up in disrupting the normal swallowing mechanism. Also, there is a loss of olfaction or smell. So, these are all the physiological effects that we see as a result of tracheostomy. Now, let's try to understand what are the indications of tracheostomy. We can divide this into different types of indications. So, one type of classification is going to be based on the type of cause, second is going to be based on the type of site involved, and third will be indications in infants and young children. So, first, let's start with indications according to different cause. This can itself be divided into five types. So, our first type over here is when there is any kind of respiratory obstruction. Second is if there is retained secretions. Third is if there is respiratory insufficiency. Fourth is if there is a need for prolonged ventilation. And fifth is when it is done as a part of another procedure. So let's start with respiratory obstruction as the main cause. Now, this can further be classified into different types of causes. There can be infectious causes like acute laryngotracheobronchitis, which is also known as CRU, then acute epiglottitis, diphtheria, Ludwig's angina, peritonsillar, parapharyngeal, or retropharyngeal abscesses. Then, looking at the traumatic cause, if there is any external injury to the larynx and trachea, if there is any trauma due to endoscopy, especially in infants, any maxillofacial injuries or mandibular fractures, corrosive injury, or inhalational injury. These will all cause respiratory obstruction. Next is neoplastic causes. Now, this can be any benign and malignant neoplasm, which involves the larynx, pharynx, upper trachea, tongue, and thyroid. If any foreign body is there in the larynx, that will also cause respiratory obstruction. Then, moving on to congenital causes, there can be laryngeal web or cysts, tracheoesophageal fistula, bilateral choanal atresia, craniofacial anomalies, and subglottic stenosis. If there is a bilateral abductor palsy, that is also an indication for doing a tracheostomy. And lastly, if there is any kind of laryngeal edema because of steam, irritant fumes, allergy, radiation, etc. So, these are all our causes which will lead to respiratory obstruction, and hence that will become an indication for performing tracheostomy. Second indication is if there is retained secretions. Now, whenever there is accumulation of secretions occurring in the lower respiratory tract, that leads to a reduction in the gas diffusion within the alveoli, as a result of which the person ends up in respiratory failure. Now, how does tracheostomy help here? As I mentioned, tracheostomy helps in reducing the dead space by about 30 to 50%. Because there is a reduction in the dead space, it reduces the amount of work required for breathing to occur. And it also makes aspirating secretions from the lower respiratory tract much easier and with less discomfort to the patient. Now, this retained secretions can be further classified into three different types of causes. First of all, is if the patient has an inability to cough, if the patient has painful cough, and third is when there is aspiration of pharyngeal secretions occurring. Now, examples of such causes are inability to cough can be seen in three different types. One is if the patient is in coma, maybe because of head injury or a cerebrovascular accident or a narcotic overdose or any kind of poisoning. Inability to cough can also be because of the paralysis of respiratory muscles, which can be seen in any kind of spinal injury or polio or GB syndrome, also known as Guillain Barre syndrome, or multiple sclerosis. And thirdly, the patient can have inability to cough also because of any spasm of respiratory muscle, which can be seen in tetanus, eclampsia, and strychnine poisoning. So, these are all the causes for when the patient is unable to cough, thereby leading to retained secretion. Second is that the patient has painful cough, which can be due to chest injury or multiple rib fracture or a case of pneumonia. And lastly, third cause is when there is aspiration of pharyngeal secretions, and this can occur in bulbar polio, polyneuritis, bilateral laryngeal paralysis. which is due to bilateral abductor palsy. Moving on to our third cause, which is respiratory insufficiency. This can be seen in chronic lung conditions like emphysema, chronic bronchitis, or bronchiectasis. And coming to the fourth cause, this can be because of prolonged ventilation. When a patient needs to be on a prolonged period of intubation, and the number important over here is more than 3 weeks of intubation required, in these cases, we choose to put the patient on tracheostomy tube rather than keeping them on an endotracheal tube. This has certain advantages. For example, the tracheostomy tube will be way more secure than the endotracheal tube. Secondly, with tracheostomy, there is a reduction of dead space, which will help in assisting the weaning of the ventilatory support. And thirdly, putting the tracheostomy tube will also reduce the length of total ventilation and hospital stay for the patient. So, for all of these reasons, whenever there is a need to keep the patient on a prolonged intubation, which is more than 3 weeks, we need to consider putting the patient on a tracheostomy. Lastly, the last indication is when tracheostomy is done as a part of another procedure. For example, permanent tracheostomy, which can be done in case of total laryngectomy and total laryngopharyngectomy, and temporary tracheostomy, which can be done for open resections involving the oropharynx or larynx. Advantage here is that the tracheostomy will allow the protection of lower airway from aspiration of blood in case of hemorrhage, as well as guard against the upper airway obstruction from postoperative swelling. So these are all the causes or all the indications of tracheostomy which are classified on the basis of cause. Let's move on to our second classification and indication, which is based on according to the site involved. Now, according to the site, if the nose or nasopharynx is the site involved, the cause over here would be the bilateral choanal atresia. Moving on to oropharynx and tongue-based causes of tracheostomy would be macroglossia, Treacher-Collins syndrome, golden hour syndrome, and cystic hygroma. Moving on to supraglottis, the causes could be supraglottic cyst or acute epiglottitis. Moving on to glottis, there could be vocal cord palsy, a bilateral abductor palsy, laryngeal edema, physical trauma, and even cases of recurrent respiratory papillomatosis. Then, as we further go down, move to the subglottis, there could be causes like subglottic stenosis, subglottic hemangioma, and lastly, moving on to the trachea, some causes involving the trachea, which are indications of tracheostomy, are acute laryngotracheobronchitis, tracheomalacia, and tracheal stenosis. So, these are the indications based on the site of obstruction or the site involved in the cause. Lastly, what are the indications in infants and children? Now, if we look at infants, most of the time the indications are because of congenital lesions. For example, it can be a subglottic hemangioma or a subglottic stenosis, laryngeal cyst, glottic web, and bilateral vocal cord paralysis. Whereas when we look at young children, the cause is usually an inflammatory cause or a traumatic cause. For example, we have acute laryngotracheobronchitis, epiglottitis, diphtheria, laryngeal edema, which can be because of chemical burns or thermal injury. There can be external laryngeal trauma, prolonged intubation, and lastly, recurrent respiratory papillomatosis. So, these are some causes that are indications of tracheostomy in infants and in children. To remember, for infants, mostly the causes are congenital, and for children, mostly the causes are inflammatory or traumatic. So, these are all about the indications of tracheostomy. Now, let's try to understand what are the contraindications of tracheostomy. Very important to remember here is the fact that there are absolutely no absolute contraindications for performing tracheostomy. If a patient urgently needs it, you can perform it. However, there are some conditions which are relative contraindications to performing a tracheostomy, which can be dealt with, but they are not if indeed a patient requires a tracheostomy right at that point of time, these won't hold true. So, in cases like uncontrolled bleeding disorder. We'll first try to control the bleeding disorder before performing an elective tracheostomy in these patients, or if the patient has unstable cervical spine injury, because the position at which we place the patient during the time of tracheostomy is we place them supine with the neck extended. So, for this, the patient's cervical spine needs to be normal. If there is some unstable injury involving the cervical spine, that acts as a relative contraindication. Third is if there is any local infection involving the incision site, or if there is some kind of difficult anatomy, for example, people who have short neck or morbid obesity or limited extension of the neck, or a goiter or some pathology involving that area like swelling of the thyroid gland, all of these end up being difficulties in performing the surgery. And lastly, if there is any high riding innominate artery or severe hypoxia or a very unstable patient, these will all act as causes of relative contraindication to perform tracheostomy. Next, let's discuss what are the different types of tracheostomy. Now, this again has different classifications over here. The first classification is depending on the timing at which you are doing the tracheostomy. Second is depending on the period of time for which the tracheostomy is kept. And third is based on the site of the incision. So, first, let's start with the first one, which is depending on the timing of our surgery. Depending on the timing, we can divide it into an elective tracheostomy or an emergency tracheostomy. So, an elective or an routine tracheostomy is a very planned procedure. It's not we have time to first find out whether we want to do this patient for tracheostomy or not, and then eventually take up the patient for tracheostomy. Now this can be further of two types. Either we are doing because of therapeutic reasons or prophylactic reasons. Now therapeutic reasons could be because we want to relieve any respiratory obstruction that the patient is facing, or to remove tracheobronchial secretions, or to give assisted ventilation to the patient. These are all the therapeutic causes. Whereas if you look at prophylactic cause, this is usually done to guard against anticipated respiratory obstruction or aspiration of blood or secretions in surgeries where we have extensively involving the tongue, floor of mouth, or mandibular resection. Usually, these prophylactic cases are often temporary and closed when the indication is over. So we end up closing the tracheostomy later on. So this is about elective tracheostomy, which is a very planned procedure. Next is emergency tracheostomy. Now this is usually done when the airway obstruction is almost complete and there is a very urgent need to establish the airway to save the life of the patient. In those cases, we perform a emergency tracheostomy. Now, this is a much rarer procedure compared to the elective tracheostomy. We usually do these cases in case of very severe trauma or very late presentation of malignancies, maybe. So, that's our first classification on the type of tracheostomy. Second is depending on the period, we can divide it into a permanent tracheostomy or a temporary tracheostomy. A permanent tracheostomy is where the continuity between the laryngopharynx and the trachea is permanently disrupted, and the cut end of the trachea is brought out to the external surface and sutured to the skin. That is when we have a permanent tracheostomy. And this is usually done as an elective procedure as a part of other surgeries like a total laryngectomy or a total laryngopharyngectomy or a case of bilateral abductor palsy. So these are all cases where we perform a permanent tracheostomy. Second is temporary tracheostomy, where a communication between the pharynx and the lower airway is still maintained via the larynx. These are cases of temporary tracheostomy. Here, only access to the lower airway is via the tracheostome. So a temporary tracheostomy is only for a very short period of time only. So that's about the classification based on the period. Third classification is based on the site of the stoma or where we place the incision. So according to this, we can divide tracheostomy into high, mid, and low tracheostomy. Now, if we look at the image over here, this is our thyroid cartilage, this is our cricoid cartilage, this is our first tracheal ring, second tracheal ring, third tracheal ring, fourth tracheal ring, and this here we see the thyroid isthmus. So this is the anatomy over here. Now, high tracheostomy is, if we look at the isthmus, this is our isthmus, anything, any incision which is done above the level of the thyroid isthmus, which is mostly done through the first tracheal ring, is known as high tracheostomy. And the only indication for this is a case of carcinoma larynx, when we have to perform a total laryngectomy or a total laryngopharyngectomy, the larynx anyway has to be removed completely, and we need to make a fresh tracheostome in a clearer area lower down. In these cases, only we'll perform a high tracheostomy here. Now, why is high tracheostomy not a common procedure? That's because if you see just above the first tracheal ring, this is the cricoid cartilage. It lies in very close proximity of the first tracheal ring. So while you are performing the tracheostomy, you can end up causing perichondritis of this cricoid cartilage, and when that happens, it can eventually lead to subglottic stenosis, which will lead to narrowing of the subglottic region. So we'll end up with a new problem over here. So that is why we do not perform high tracheostomy in usual cases. The only indication for it is to perform is in case of a carcinoma of larynx. Next is a mid tracheostomy. Now, a mid tracheostomy is which this is the more commonly done method. A mid tracheostomy is done when we are doing in the region of the isthmus, which is the second or the third tracheal ring. And this involves either we retract the isthmus upwards to expose the trachea, or sometimes we may even need to divide the isthmus at the center and ligate it. So, this mid tracheostomy is the most common procedure done. And low tracheostomy is any kind of tracheostomy which is done below the level of isthmus, which is the fourth tracheal ring, usually. This also has its own disadvantage. The disadvantage being the trachea is deep at this level and very close to a lot of large vessels. So, you may end up injuring some of the large vessels while performing a low tracheostomy. So, the most common and the most preferred one here is a mid tracheostomy, which is done through the second or the third tracheal ring. So, that's about the different types of tracheostomy. Next, let's try to see what are the advantages and what are the disadvantages of performing a tracheostomy. First, looking at the advantage, a tracheostomy tube can be kept for a very prolonged period of time. Now, these advantages or disadvantages are on the basis of comparison to intubation. So, for an intubation for an endotracheal tube, you cannot keep it for a prolonged period of time before it gets blocked. Whereas a tracheostomy tube has the advantage of that it is easy to keep it for a very long period of time. With a tracheostomy tube, patient can swallow. Also, they have increased patient mobility and comfort compared to intubation. There is a decrease in dead space by 30 to 50% and a decrease in the respiratory resistance, all of which is leading to increased airway ventilation. So, these are also some advantages that we are seeing with tracheostomy. Tracheostomy is also something that is easy to maintain, less chances of causing tracheal stenosis. Tracheal toileting becomes very easy, and there is no risk of main stem bronchus intubation with these cases. So, these are all our advantages of tracheostomy over intubation. Lastly, for today's class, we'll talk about the disadvantages of this thing. Now, tracheostomy is a proper surgical procedure, so it takes a lot more time than performing an intubation. Second, a decannulation. Decannulation meaning when we are removing the tracheal tube. The decannulation sometimes can end up being difficult. I'll talk about this in a separate video where I discuss on decannulation and what are the different causes for difficult decannulation. Third disadvantage is performing a tracheostomy leads to increased risk of infection because there is more bacterial colonization occurring here. Next, a redundant area gets created between the tracheal opening and the larynx, in which mucus tends to accumulate and then fall back into the lungs. Next is the patient can will have the problems, the physiological problems that I mentioned earlier, that there is a loss of nasal filtration and humidification of the inspired air. That will be lost. So that is also a disadvantage here. Next is the tracheostomy tube can act as a foreign body itself. Here, the patient is not able to cough or phonate, and this the procedure itself may end up in a disfiguring scar, especially if a vertical incision has been used. And lastly, it takes more time than intubation. So these are our advantages and disadvantages of tracheostomy. That's all for our class today. In my next class, I'll be talking about the steps of tracheostomy, how do we perform this procedure, and then what is the postoperative care for these patients, and what are the different aspects we need to keep in mind to take care of the tracheostomy patients. See you in my next class.